This video will demonstrate the complete assessment and classification process for a young infant age up to 2 months and then for a child age 2 months up to 5 years.
During the assessment, it is important for the health worker to establish good communication with the mother. First, the health worker welcomes the mother and asks the child's name and age. She asks the mother what the child's problems are. She asks if this is the first visit for these problems or a follow-up visit.
She speaks to the mother in terms she will understand and ensures that she understands the questions which are being asked. The mother is praised for bringing the child to the clinic.
The health worker is then ready to begin the assessment. You will now learn how to assess and classify a young infant for a possible bacterial infection. Young infants can become sick and die very quickly from a bacterial infection. They may show only non-specific signs of an infection, such as few movements, fever, low body temperature, nasal flaring or fast breathing. Check every sick young infant for all of the signs of a serious bacterial infection. We will now show you how to assess a young infant for possible bacterial infection. First, ask the mother,
has the young infant had convulsions?
Make sure that the young infant is calm and then count the breaths in 1 minute. The cut-off rate for fast breathing in young infants is higher than it is for older children. A young infant aged up to 2 months has fast breathing if you count 60 breaths per minute or more. The breathing of young infants is often irregular. The young infant will occasionally stop breathing for a few seconds. This may then be followed by a period of very fast breathing. Therefore, if you count 60 breaths or more, repeat the count to see if the fast breathing is sustained. Only if the breathing rate is 60 breaths or more on the second count should you consider it to be fast breathing in a young infant. Next, look for severe chest indrawing.
Chest indrawing occurs when the effort required to breathe in is much greater than normal.
To look for chest indrawing, you must know when the child is breathing in. When the child breathes in, the upper chest and abdomen move out. Breathing in, breathing out. Breathing in, breathing out. Breathing in. This is a healthy child with normal breathing. When the child breathes in, the upper chest and abdomen move out. The lower chest also moves out. This child has chest indrawing. When the child breathes in, the upper chest and abdomen move out, as in the healthy child, but the lower chest moves in. Chest indrawing is this inward movement of the lower chest wall when the child breathes in. Look again. Breathing in, breathing out. Breathing in, breathing out. Breathing in. When the child breathes in, the upper chest and abdomen move out, while the lower chest moves in.
The lower chest wall goes in when the child breathes in. Chest indrawing is only significant if it is present all the time and definitely visible. This child is breastfeeding. If you see chest indrawing only when a child is upset or trying to feed, but not when resting peacefully, do not call it chest indrawing. This child only has chest indrawing when feeding. Therefore, we would not call it chest indrawing.
Mild chest indrawing is normal in young infants because their chest wall is soft. It is not a sign of illness in young infants. This young infant has mild chest indrawing. However, severe chest indrawing is a sign of illness. Severe indrawing is a very deep movement and is easy to see. This young infant has severe chest indrawing.
We will now assess this young infant for fast breathing and chest indrawing.
You should write down the number of breaths you count and then decide whether or not the child has fast breathing. You will be told when to start and when to stop counting. After 1 minute, this symbol will appear on the screen, and there will be a pause. You will have time to write down the result of your count and to decide if the child has fast breathing.
Count the breaths Abdi takes in 1 minute. Find an area of the abdomen to watch. Prepare to start counting. Start counting now. Stop counting. How many breaths did you count? We counted 70 breaths per minute. As Abdi is less than 2 months old, and we counted 60 breaths per minute or more, you would repeat the count to see if the fast breathing rate is maintained. If you again count 60 breaths or more in the second count, Abdi has fast breathing. Now look for chest indrawing. Abdi has severe chest indrawing. The indrawing is deep and easy to see.
Look for nasal flaring.
This young infant has nasal flaring. Nasal flaring is a widening of the nostrils when the young infant breathes in.
Look and listen for grunting.
This young infant has grunting. You may hear short, soft sounds as the infant is breathing out. This young infant has grunting.
Look and feel for bulging fontanel. The fontanel is the soft spot on the top of the young infant's head, where the bones have not formed completely. Check the fontanel while you are holding the child in an upright position and the child is not crying. This child's fontanel is normal. If the fontanel is bulging rather than flat, this may mean the young infant has meningitis, a serious bacterial infection.
This child has a bulging fontanel.
Look for pus draining from the ear. Look closely into each of the child's ears. Pus draining from the ear is a sign of infection. Look at the umbilicus. Is it red or draining pus? This is a normal umbilicus. It has no redness or pus.
This umbilicus is showing some signs of infection.
Look for skin pustules. Examine the skin on the entire body.
Skin pustules are red spots or blisters which contain pus. If there are many pustules or a big boil, this is a serious bacterial infection. This young infant has many skin pustules.
Measure temperature, or feel for fever or low body temperature. Fever is uncommon in the first 2 months of life. If a young infant has fever, this may mean the young infant has a serious bacterial infection. In addition, fever may be the only sign of a serious bacterial infection.
Young infants can also respond to infection by dropping their body temperature. If you do not have a thermometer, feel the infant's abdomen or underarm to determine if it feels hot or unusually cool.
See if the young infant is lethargic or unconscious. It is normal for young infants to sleep most of the time. The young infant should wake to noise or if he is moved. There is no difficulty in waking this young infant. He is not lethargic. He stays awake.
If a young infant does not wake up during the assessment, flick the sole 2 to 3 times and look for the response. This young infant wakes up and remains awake. This young infant wakes up momentarily but sleeps again. He has poor response to flicking of the sole and is therefore lethargic.
Look at the young infant's movements. Are they less than normal? An awake young infant, such as this, will normally move his arms or legs or turn his head several times in a minute. Observe this as you do the whole assessment. This young infant has normal movements.
This young infant is moving less than normal.
Next, check the young infant for severe jaundice. A young infant with severe jaundice needs urgent attention in a hospital. Mild jaundice during the first week of life is usually normal, but yellow palms and soles always indicate severe pathological jaundice. Look for yellow palms and soles. Press the soles with your thumbs to blanch, remove your thumbs and look for yellow discoloration. Repeat the process for palms. This young infant does not have yellow palms and soles. This young infant has yellow palms and soles. This completes the assessment of a young infant for possible bacterial infection and for severe jaundice. In this exercise, you will have the opportunity to practice counting breaths and looking for severe chest indrawing in young infants. Count the breaths taken in 1 minute in the following 2 young infants. Here is the first young infant. Count the breaths the young infant takes in 1 minute. Prepare to start counting. Start counting now. Stop counting. How many breaths did you count? We counted 68 breaths per minute. This young infant has 60 breaths or more, and therefore you will repeat the count. If the breathing rate on the second count is also 60 breaths or more, the young infant has fast breathing. Here is the second young infant. Start counting now. Stop counting. How many breaths did you count? We counted 64 breaths per minute. This young infant has 60 breaths or more, and therefore you will repeat the count. If the breathing rate on the second count is also 60 breaths or more, the young infant has fast breathing. Now, assess the following 5 young infants for severe chest indrawing. Here is the first young infant. Does this young infant have severe chest indrawing? What did you decide? Write down your assessment. Here is the second young infant. Does this young infant have severe chest indrawing? What did you decide? Write down your assessment. Here is the third young infant. Does this young infant have severe chest indrawing? What did you decide? Write down your assessment. Here is the fourth young infant. Does this young infant have severe chest indrawing? What did you decide? Write down your assessment. Here is the fifth young infant. Does this young infant have severe chest indrawing? What did you decide? Write down your assessment.
To assess for the main symptom of diarrhea, ask,
Does the child have diarrhea?
if the mother says yes, assess further. Ask,
For how long?
the number of days determines whether the child has persistent diarrhea. Next ask,
Is there blood in the stool?
blood in the stool is a sign of dysentery. Then every child with diarrhea is assessed for signs of dehydration. To assess for dehydration,
Look at the young infant's general condition. Is the young infant lethargic or unconscious? Is the young infant restless and irritable? This young infant is not lethargic or restless and irritable. This young infant is lethargic.
look at the child's eyes.
This child has eyes which are sunken. If you're not sure if a child's eyes are sunken, you should ask the mother whether the child's eyes look unusual to her.
Pinch the skin of the abdomen. Does it go back very slowly, taking longer than 2 seconds? Does it go back slowly? Or does it go back immediately?
To pinch the skin of the abdomen, ask the mother to hold the child so he's lying flat on her lap. Locate the area on the child's abdomen halfway between the umbilicus and the side of the abdomen. Place the thumb and first finger on the skin of the abdomen so that when you pinch the skin, the fold of the skin will be in a line up and down the child's body and not across the child's body. Firmly pick up the skin and some fat beneath the skin. Pinch the skin for 1 second and then release it by separating your thumb and first finger. When you release the skin, look to see if the skin pinch goes back very slowly, taking longer than 2 seconds, slowly, or immediately. This child's skin goes back very slowly, taking longer than 2 seconds. With this child, the skin goes back slowly, in less than 2 seconds. With this child, the skin pinch goes back immediately.
To correctly assess dehydration, consider each of these signs and use them to classify the child as having severe dehydration, some dehydration, or no dehydration.
You will now have the opportunity to practice what you have learned using an actual case study. Gemma is 45 days old. Her weight is 3 kilograms. Her temperature is 37 degrees auxiliary. Gemma has been brought to the clinic by her mother because she is sick. First, check for possible bacterial infection. Ask,
Has the infant had convulsions?
The mother says, no. Count the breaths in 1 minute. Prepare to start counting. Start counting now. Stop counting. How many breaths did you count? Write down your answer. Repeat the count if you decided it was elevated. Next, look for severe chest indrawing. Does Gemma have severe chest indrawing? Write down your answer. Look for nasal flaring. Does Gemma have nasal flaring? Look and listen for grunting. Look and listen now. What did you decide? Write down your answer. Look and feel for bulging fontanel. What is your assessment? Does Gemma have a bulging fontanel? Look for pus draining from the ear. There was no pus draining from either of Gemma's ears. Look at the umbilicus. Is it red or draining pus? Look for skin pustules. Are there many or severe pustules? Write down your answer. Measure temperature or feel for low body temperature. Gemma's temperature is 37 degrees. See if the young infant is lethargic or unconscious. Write down what you decide. Look at the young infant's movements. Are they less than normal?
Look at the young infant's palms and soles. Does Gemma have yellow palms and soles? This completes the assessment of a young infant for possible bacterial infection and for severe jaundice.
Then ask,
Does the young infant have diarrhea?
the mother says yes.
For how long?
The mother replies, for 4 days.
Is there blood in the stool?
The mother says no. Look at the young infant's general condition. You already assessed whether the child was lethargic or unconscious when checking for possible bacterial infection. Now look to see if she's restless and irritable. What did you decide? Write down your answer. Look for sunken eyes. Are Gemma's eyes sunken? Pinch the skin of the abdomen. Does it go back very slowly, taking longer than 2 seconds? Does it go back slowly? That completes the assessment for diarrhea. Now classify Gemma for diarrhea. We will then tell you how we classified Gemma for bacterial infection and diarrhea. We will now tell you how we classified Gemma's illness. Gemma is aged 45 days. She has been brought to the clinic by her mother because she was sick. First, we checked Gemma for possible bacterial infection. The mother said that Gemma has not had convulsions. We counted the breaths in 1 minute. We counted 42 breaths in 1 minute. Gemma does not have fast breathing. As Gemma was taking less than 60 breaths per minute, we did not repeat the count. Next, we looked for severe chest indrawing. We decided that Gemma did have severe chest indrawing. We decided that Gemma did have nasal flaring. We heard grunting when Gemma was breathing out. Gemma did not have a bulging fontanel. There was no pus draining from either of Gemma's ears. The umbilicus is not red or draining pus. Gemma does not have a fever. Her temperature is only 37 degrees. Gemma does not have skin pustules. We decided that Gemma was lethargic and that her movements were less than normal.
We decided that Gemma does not have yellow palms and soles.
We looked at the pink section of the bacterial infection table. Gemma's signs of severe chest indrawing, nasal flaring, grunting, being lethargic, and movements less than normal are signs of possible serious bacterial infection.
Because Gemma does not have yellow palms and soles, she was not classified as severe jaundice.
Next, we assessed Gemma for diarrhea. Gemma's mother told us that Gemma has had diarrhea for 4 days. There is no blood in the stools. We looked at the child's general condition and decided that Gemma was lethargic. Gemma's eyes were not sunken. When the skin of the abdomen was pinched, it went back very slowly. Look at the pink row of the classification table. Gemma is lethargic, and her skin pinch goes back very slowly. These are signs of severe dehydration. We therefore classified Gemma as having diarrhea with severe dehydration. Because Gemma had only had diarrhea for 4 days, she was not classified as severe persistent diarrhea. Because she had no blood in the stool, she was not classified as dysentery. We therefore classified Gemma as having possible serious bacterial infection and diarrhea with severe dehydration.
This section of the video shows you how to check the young infant for feeding problem and malnutrition, including how to assess a breastfeed.
First, ask the mother.
Is there any difficulty feeding?
Ask.
Is the infant breastfed?
If the mother answers yes, ask.
How many times in 24 hours?
Next ask.
Does the infant usually receive any other foods or drinks?
If the mother answers yes, ask.
How often?
Then ask.
What do you use to feed the infant? Look for visible severe wasting.
Look for severe wasting of the muscles of the shoulders, arms, buttocks and legs. The hips look small compared to the chest and abdomen. Look at the child from the side to see if the fat of the buttocks is missing. Determine the young infant's weight for age. You need to assess breastfeeding if the young infant has any difficulty feeding, is breastfeeding less than 8 times in 24 hours, is taking any other foods or drinks, or is low weight for age, and has no indications to refer urgently to hospital. Assess breastfeeding in the following way.
Ask, do you have pain while breastfeeding? If the mother says yes, look for sore nipples and breast engorgement or breast abscess.
Ask,
Has the infant breastfed in the previous hour?
if the young infant has been fed and is not interested in feeding, ask the mother to wait and tell you when the young infant is ready to feed again. If the infant has not fed in the previous hour, ask her to put him to the breast. Observe the breastfeed for 4 minutes. Is the infant able to attach? Look for the 4 signs of good attachment. Good attachment is essential for the young infant to feed well.
The 4 signs of good attachment are the chin touching the breast, the mouth wide open, the lower lip turned outward, more areola visible above than below the mouth, this young infant is well attached with the chin touching the mother's breast. This young infant is attempting to feed with its chin not touching the breast. There is an obvious gap between the young infant's chin and the mother's breast. This child is not well attached. When the young infant is well attached, the mouth is wide open. This young infant is feeding with its mouth wide open. This young infant is feeding with its mouth partially closed. It is not well attached to the mother's breast and is therefore having difficulty feeding. When the young infant is well attached, the lower lip is turned outward. With this young infant, you can clearly see the lower lip turned outward while he is feeding. With this young infant, the lower lip is turned inwards. It is not well attached. When the young infant is well attached, more areola is visible above than below the young infant's mouth. With this young infant, you can clearly see more areola above than below the mouth. If there is the same amount of areola above and below the young infant's mouth, as in this child, or if there is more areola visible below than above the child's mouth, the young infant is not well attached. When a young infant is well attached, as in this case, he shows all 4 signs of good attachment.
Then look to see, is the infant suckling effectively?
When a young infant is suckling effectively, he takes slow, deep sucks. Sometimes he pauses and then starts suckling again. You may be able to see him swallow. This young infant is suckling effectively. This young infant is not suckling effectively. The young infant is making mostly rapid sucks. You cannot see swallowing. A young infant who has had a good breastfeed will stop suckling and release the breast spontaneously. He has had enough and is satisfied. He has lost interest in the breast and he appears relaxed and sleepy. This young infant demonstrates the signs of good attachment. The chin is touching the breast. The mouth is wide open. More areola is showing above than below the young infant's mouth. However, you cannot see the lower lip. This is because she is very close to the breast, making it very difficult to see her mouth at all. This sometimes happens with babies who are very close to the breast. We asked the mother to hold back her breast so that we could see what was happening with the lower lip. You can see that the lip is turned outwards. If a baby is very close to the breast and shows the other signs of good attachment, the young infant is probably well attached. You do not need to hold back the mother's breast to check the lip. You can see that this young infant is giving slow, deep sucks, sometimes pausing and swallowing. The young infant is suckling effectively.
Look for ulcers or white patches in the mouth. Ulcers or thrush can make it difficult for the infant to suckle.
If an infant does not suckle effectively, the breast milk does not flow well, and the infant gets it slowly. He may want to suckle very often, or for a long time, or he may gain weight too slowly. If an infant is poorly attached or not suckling effectively, you should help his mother to position and attach him better.
If a mother positions her infant well at the breast, it helps the infant to attach well and to breastfeed effectively. In a well-positioned child, the neck is straight or bent slightly back. The infant's body is turned towards the mother. The infant's body is close to the mother. The infant's whole body is supported. This infant is well positioned. His neck is straight. He is turned towards his mother. His body is close to his mother's. And his whole body is supported. The following are signs that an infant is poorly positioned and that it may be difficult for him to attach well and breastfeed effectively. If the infant's neck is twisted or bent forward. If the infant's body is turned away from his mother. If the infant's body is not close to his mother. If only the infant's head and neck are supported. If any of these signs are present, the infant's position may need to be improved. This infant is poorly positioned. His neck is twisted. The child is on his back, with his body turned away from his mother. The infant's body is not close to the mother. She is not supporting his whole body. This infant is poorly positioned. The infant's body is not close to his mother and is not well supported. You will now learn the steps to help a mother to position and attach her baby correctly. First, make sure that the mother is in a comfortable position and that she's relaxed. If she's sitting, she should be on a low seat and her back should be straight. If she's lying down, she should be on her side in a position in which she could sleep comfortably. She should hold her infant with his head and body straight and facing her breast. With his nose opposite her nipple. She should hold the infant close to her body, and she should support his whole body, not just his head and neck. When the young infant is in a good position, show the mother how to help him attach to the breast. She should touch her infant's lips with her nipple. Wait until the infant's mouth is opening wide, then move her infant quickly onto her breast, aiming the infant's lower lip well below her nipple. Let's watch that again. The mother touches her infant's lips with her nipple, waits until the infant's mouth is opening wide, then moves her infant quickly onto her breast, aiming the infant's lower lip well below her nipple. Look for signs of good attachment and effective suckling. You can see that this infant is well attached and suckling effectively. If the attachment or suckling is not good, take the baby off the breast and try again. It may be necessary to try several times, and for the mother to practice at several feeds to get her baby to attach well every time. Explain to the mother what to do, so that she can practice attaching the baby correctly when she's at home. Explain to the mother that if her baby is well attached, she should let him feed as often as he wants. Breastfeeding 8 or more times a day helps to ensure a good supply of milk. Explain that at each feed, she should let her baby breastfeed for as long as he wants. She should not stop the breastfeed before her baby is ready. Let him release the breast by himself. Ask to see the mother and baby again in 2 days.